All right, you're good to go.
Ready?
Yep.
Morning. Everybody for getting home after the Easter weekend.
Yeah. There you go.
Ramp up this morning. So, Adam asked me to talk a little bit about shoulder stuff. Y'all have been going through, I guess, some anatomy and exams and some of that. So, we'll talk a little bit about things like we did on knees and ankles and feet, and some of the things that we see, and some of that y'all will be seeing, and just give you an introduction to how we treat some of those, more for your own education background. Most of y'all have scrubbed in or seen us do some shoulder surgery, and so it's the shoulder is one of those things that, as I look back when I got out of residency, I'm not sure I really understood the anatomy of the shoulder that well, and arthroscopic surgery has really helped understand how things kind of fit together and how they work, as opposed to cutting things open, doing big open procedures. And for those of y'all that were, have been in surgery when we've done some shoulders, hopefully it'll help you get a three-dimensional understanding of what the shoulder is, where the biceps tendon is, where the middle glenohumeral ligament, what it is and where it is, rotator cuff stuff, things like that. So we'll kind of go through some of that, and it won't be a real long talk because I can tell you everything I know about shoulders, so it'll be we can go through pretty quick, but it's something I enjoy doing, particularly the rotator cuff arthroscopic treatments. It's a little challenging to be able to do that through the scope like that. So we'll talk a little bit about anatomy. Y'all been through this. Scapula, glenoid, humerus, clavicle, soft tissue stuff, capsular ligaments, labrum, rotator cuff. Show you a couple fractures and how we treat those, and that'll be somewhat familiar with y'all and some of your injuries that you'll see, particularly things like football. And of course, dislocations, AC joint, glenohumeral joints, and then soft tissue injuries, slap, bank arch, rotator cuff, bicep tendon injuries, and then some of the procedures we do for those. Stop me anytime that you got any questions, of course. This is a conversation, not just a lecture. So, of course, the anatomy is pretty straightforward. When you get a good three-dimensional idea of what's going on up there, then it makes understanding the injury patterns and how you treat those a little bit easier. The ligaments are a big part of what we treat in injuries to the shoulder. The ones that we talk a lot about is the ligaments within the shoulder joint right there, the capsular ligaments. You got a superior, middle, and inferior glenohumeral ligaments, anterior and posterior. The ligaments from your clavicle up there, the corticoclavicular ligaments. You got a conoid, which is kind of cone-shaped, and a trapezoid, and we'll talk a little more about those and AC separations. The coracoacromial ligament, which runs from the coracoid over the acromion, is kind of a neat little structure. We see when we're scoping them, and occasionally get rid of it in impingement problems, but we also use it for some of our reconstructive procedures. Biceps tendon down there at the bottom, we'll talk about it in a little bit too. So, cross section, the labrum is one of the things that we'll address, and we see a lot of injuries. Y'all see slap tears, Bankart tears, which involve the labrum, and you can see it in cross section labeled there. It's really it's kind of an extension of the joint. You think of the shoulder as being a basketball on a plate. There's not a lot of stability to it. It's not like a ball and socket that fits in there. So how do you increase the stability of the shoulder? Well, you have ligaments and muscles, the ligaments being very static and the muscles being dynamic. But the labrum also extends the surface area, and it works to make it a little more stable. It actually creates a suction where the head stays onto the glenoid right there. If you stick a needle, which if you've seen us do shoulder scopes, I inject the joint with lidocaine to start with, and you stick a needle into the joint, you'll hear it go like that because it releases the vacuum in there. There's actually a suction that keeps that head, and that may be one of the reasons that people have problems with tears of the labrum, is they lose not just the bumper effect, but also the suction effect, and so the head's a little wobbly. Same thing happens when you tear the rotator cuff up on top, is you lose that suction effect in there, and the head wobbles around on the plate. Of course, the muscles are important, particularly the rotator cuff muscles. You have 4 of them, one in the front, subscap, one on top, supraspinatus, and then the infraspinatus and teres minor in the back. We don't mess too much with the posterior muscles, the ones we usually are addressing more of the supraspinatus on top with rotator cuff tears, and the subscap in the front with anterior dislocations and instability patterns there. And if you've seen in surgery, there's really not a big gap like that. They're more continuous all the way around, or supposed to be anyway. And they also are continuous with the capsule. You can dissect them apart if you go more medial, but they really are one big structure kind of blending in together. So, talk a little bit about fractures and how we treat those. You probably are not going to see a whole lot of fractures of the humeral head in athletics, but occasionally you may. These are typically more older patients that are going to fall and break it into several parts, the shaft, the head, the greater and lesser tuberosities. And quite common actually in older folks, and they're a real problem to fix. They're difficult to fix and they don't do well and they all end up stiff. So a lot of those we end up treating non-operatively. This one you may see actually, that's a greater tuberosity fracture, and it does occur in athletics occasionally. And that one you would fix. You'd go in and put some screws or a plate down. And the reason is the rotator cuff hooks to that where it comes over the top. And that piece will a lot of times get displaced up superiorly, but you occasionally see that in athletics. And when we get these big crunch, this is standard plate most of us use. It's made just for treating these fractures, and got all kinds of screws. These all diverge at different angles, and the screws actually screw into the plate. You've seen some of these style of plate that we fixed other fractures with. The purpose of, it's kind of neat when they first came out with some of these plates. The screws all go different directions like this, and if you take that plate and you lay it on an apple and you put all these screws in, you absolutely can't pull it off the apple. It's really amazing how much stability it gets with that. But the problem with this fracture is that when you break through the head, the blood supply is disrupted and the head dies, called ABN. So that's a real complication with some of these older folks, but in younger patients can also have that too. This one you will see quite often, clavicle fractures. Paxton, I guess, was our last one we addressed with this. This is actually pretty close. This isn't his x-ray, but it's pretty close to what he had. A lot of times you'll see a midshaft fracture with a piece in between. Usually there are 2 or 3 pieces like that, very common. The history of treating clavicle fractures has kind of changed a lot in the last 10 or 15, 20 years. If you look at the literature, in the old days, we never operated on these things. Everybody was treated non-operatively. And part of that is that the literature shows that probably 90% of them will heal, maybe even higher than that. The problem is there are 5 or 10% that don't heal. And there's some studies that show that if you don't restore the length, particularly in an athlete, they lose strength. And so there's been a little bit of a push to be more aggressive with treating these. The other part that's been part of that is we just didn't have a good way of fixing these things. The old standard plates we had, we tend to pull loose. They're just a plate with a hole in them, and so you put screws into the bone, and those plates could, even though it was in the bone, it actually moves in the plate. But now that the screws actually screw into the plate, it's a little more rigid, because the clavicle, remember, it can bend this way and it can bend this way and it can rotate. So there's a tremendous amount of force on that little bone. So the plates didn't hold up. There are other ways they've tried treating them. They've tried putting rods and kind of shish kebab the deal. There's some classic pictures of where sometimes those pins or rods migrated. There's one that we used to see in residency where the pin or the rod was actually in the chest down here somewhere. Not good. Does a lot of damage rolling around inside your chest cavity right there. So the third thing we'll do, and Paxton can tell you, they really help with pain control, because these things are really painful. And anytime you move, they move, and for about 3 or 4 weeks until they start getting really sticky, they're really painful. You can go in there and put a plate on them, and they're almost pain-free. It's amazing how quick they can get over the initial pain of the fracture. So we've become more and more aggressive about treating these, unless they're just absolutely non-displaced. We'll go in and fix them. Biggest problem you tend to have long-term, though, is sometimes those plates bother them because it's right under the skin right here. And be interesting to see how he does. Some of my football players in the past have had trouble with the shoulder pads hitting on the plate right there. For the rest of us mortals, it's not a big deal, but sometimes the pads can hit them and you'll come back and take the plate out down the road a little bit. And I usually wait 6 months to a year, and then you have to wait about 6 weeks for contact because of the screw holes. They'll break through those screw holes, but he's a good one for you guys to kind of follow along because he's here, and we usually protect them about 6 or 8 weeks, let them heal up, and then let him get it back to more heavy lifting. But in the meantime, first couple of weeks you kind of shut them down, and then at 3 to 6 weeks let them go ahead and start doing some light resistive stuff. The problem with a lot of these athletes is they tend to push the limits a little bit, so we tend to hold them back a little more because you can't trust them to go out and behave themselves, and they're out there trying to lift or do things like that, and a little fast, and so you just want to make sure that you'd rather go a little slow than a little too fast, and off they go. But that'll be a pretty common injury that we see off and on.
Is there a spot on the path where you can't do that?
Yeah, it gets difficult when you get towards the end laterally. There's a stand, I mean, that's almost exactly kind of what we put in him. The screw right in the middle, that's an interfrag screw that sometimes you can get them oblique. You'll put one across to hold it, and then you'll span it with the plate. But when you get towards the very tip end laterally, becomes a problem, yeah, because you don't have anything on the end to fix it to. They make a plate, I don't have a picture of it, it's called a hook plate, and it looks like that, and then it makes a little U, and then it's got another piece sticking out. And what you actually do is stick it through the AC joint and underneath the acromion out there. So you get screws medially, and then that thing goes underneath the acromion. Some people actually plate it right across to the acromion, and then plan on coming back and taking it out later. I like the hook plate because even still, you still gonna get a little rotation right there at the AC joint. But that ends up being a little bit of an issue on that. The comminution in there makes them a little tough too sometimes because they can really get they get a direct blow to it, and then you're kind of lots of pieces together with that. But most of the time they're usually mid shaft or far enough out that you try to get 3 screws laterally. Medially, if you get way far medial, it gets a little hairy because there are big things right underneath the clavicle with names on them that you don't like to see or hear about. And so generally you're not going to see too many medial fractures, and a lot of those won't displace much because you have a lot of muscle hooking to them, so they're usually treated non-optically. But that's a typical fracture fixation right there. We got plates, they come in rights and lefts, and they got all kinds of curves, and none of them fit, but they're supposed to be somewhat anatomic, so you can just lay them on there. In the old days with their old plates, you used to spend 30 minutes in surgery just sitting there, kind of keep bending the plate, trying to make it fit. And these are pretty close now, and we do all kinds of gymnastics trying to get them to fit in there. Sometimes we'll take a right and put it on the left, or sometimes you'll turn it backwards and put it on that way just to figure out how to make it fit without having to do too much actual bending yourself. That becomes a little bit of a challenge on some of these, particularly if they're really unstable and it's hard to get them to hold them there while you're trying to get the plate fixed on. AC joints, really a dislocation or separation they call it. 1, 2s, and 3s. Remember, 1 is just a sprain of the ligaments there at the capsule. 2 is where you rupture the ligaments there, but the other ligaments, conoid and trapezoid ligaments, are still intact, so it binds up on x-ray about 50% of the thickness. And the 3rd one's where you tear both of them and they ride up way above the acromion right there. There's also a 4, 5, and 6 that hardly ever seen. One of them is where it goes back into the trapezius muscle, one's where it goes down underneath the coracoid, and the other one's where it's sticking in their ear. So those are hardly ever seen, but they're always operative interventions on those because of the severe displacement. And obviously, the ones that go inferior can actually press on some neurovascular structures. So those are usually motorcycle guys who, crash and burn. The treatment of this on grade 3 is somewhat controversial. Most of the time we treat those non-operatively, but occasionally we'll treat them surgically. There is some literature that shows that particularly in throwing and overhead athletes or heavy manual laborers will do better if you treat a grade 3 surgically. The problem is it's just not a good way to do that. And it's in our literature, you'll see about 20 different ways of doing that. When you see 20 different ways of doing something, that means not one of them is any good. They all have problems, and I very rarely do them. Here's one way of doing it. That's like an endo button type thing that you drill through the acromion to try to hold it down. The problem is it erodes through the bone. Kind of another look at that. Weaver Dunn was one way of doing it, where you have to take that cochleoacromial ligament that we talked about up there, and you take it off the little bone. You take the end of the clavicle off, and you stick it in there, and you use that ligament to substitute for the CC ligaments up there. Some people will use a tendon. They'll take a tendon out somewhere, or an allograft tendon, and use it to make that. There's just lots of different ways of doing it. I've probably done one or two in my career, 30 years, and it was a guy that had type 4 sticking up in his ear up there. They never get back to normal. They're always a little bit high, and sometimes you'll end up with some arthritic changes at the AC joint right there. So most of these we treat non-operatively, but occasionally you'll see somebody get treated. Okay, moving on to something else that's also very common, shoulder dislocations. See these all the time, pretty common in a lot of sports, particularly football.
Dr. Stark, do you remember, and I told them about, do you remember Proctor, Byron Proctor? Mm-hmm. Remember that in the game that we had? And I was trying to tell him, I said that it almost seemed like he dislocated it posteriorly, and we both were kind of looked at each other, and so we shut him down immediately because it wasn't normal. And then we went and x-rayed him at your place afterwards, and it was back in place.
Yeah.
And so we just kind of said, okay. And you said, Adam, well, treat him, and if it gets any worse, call me. And so it was a 6 to 8 week protocol. We just restored range of motion, decreased his pain. We both were kind of miffed at what happened because when we took the x-ray, everything was back in place and it was totally fine. But on palpation and evaluation during the game, he didn't have an AC joint, or it was so swollen you couldn't feel it. And so it was very strange. But after we went and evaluated him, it wasn't any immediate danger. And we both kind of went, okay, cool. And so we just treated it and went on from there. And he really didn't have any problems. Unfortunately, he didn't continue school because of academic issues. So we really couldn't follow up with that anymore. But it was just kind of okay. And I guess the only other question I had for you is, I guess, could you evaluate or extrapolate a little bit more on when they have when they have like arthritic change on the end, and sometimes you have to do resection on that, kind of like with CRISP, on what you did there.
Very common that particularly a lot of athletes who do a lot of heavy lifting will get AC joint arthritic changes there. And sometimes you'll see that when they're 40 and 50 years old, down the road, just from the